Good morning, everyone. I'm John Quinones, longtime ABC News correspondent, and of course the host of that hidden camera show, What Would You Do? So you've been warned. We can put those hidden cameras anywhere. Like in this room, if you're sitting there and someone passes out, and you step over them to go get another drink, you're going to have me to talk to. Welcome to our session titled Follow the Money for Good, hosted by Methodist Healthcare Ministries. Joining us are a very special group of leaders who are doing truly powerful work to shape the future of health in our communities. I'll invite each of you guys to do short introductions, starting with Allison Neiman, and then Dr. David Ansell, and then Jamie Weslowski.
Thank you, John. Good morning, everyone. My name is Allison Neiman, and I serve as the CEO of Mindful Philanthropy. We are an organization that catalyzes impactful funding to mental health, addiction, and well-being. We serve as a field catalyst, and our goal is to see the increase in funding and philanthropic funding over the next 10 years.
Next.
And my name is David Ansell. I'm a primary care doctor for 50 years.
Wow.
And I've held a lot of roles in medicine, but I'm the Senior Vice President for Community Health Equity at Rush University System for Health in Chicago.
Jamie.
And I'm Jamie Weslowski. I'm the President and CEO of Methodist Healthcare Ministries of South Texas. And we are on the journey of advancing health equity by supporting and sustaining long-term generational health and well-being.
And today, we're here to talk about the changing and then sometimes ingrained, even though well-intentioned, ideas around how we should support our community well-being and the assumptions around how we see people. On my hidden show, What Would You Do? We seek to illustrate and inspire people to look beyond the circumstances of situations, to truly see people as their neighbors. In each of the stories we do, the organizations here today, there is a theme of bold steps of responsibility taken to do what's better. And that's where I'd like to begin our conversation today. Jamie, can you tell us a little more about the bold steps that MHM has taken to further the idea of following the money for good?
Yeah, absolutely. Thank you. So let me tell you a little bit about Methodist Healthcare Ministries, first of all. We are a faith-based, not-for-profit organization, clearly tied to the United Methodist Church. And our mission statement is serving humanity to honor God. We focus on serving the least served in South Texas. We serve 74 counties, which is about a third of the state, almost 8 million people. We also are 50% owner of the largest hospital and health system in South Texas, Methodist Healthcare. And so we take the money from the proceeds of the healthcare system, and we do a few things with that. First of all, we provide direct services, medical, dental, behavioral, for the uninsured. We also give grants out to organizations throughout Central and South Texas. We have a strong policy and advocacy arm of Methodist Healthcare Ministries. And then finally, we really work in communities, community-centered work. And I would say that for 23 years, we focused on downstream work, working on direct services. And in 2018, our board took a bold initiative to really do an audit of the impact of our investments so far. And they really took a look at the health outcomes of the population we serve. So when I say our service area is 8 million people, probably the least served is close to 2 million people that we really service. And so by doing strictly downstream work, we were actually servicing 50,000 people. And the health outcomes of those 50,000 people were better because we did that. But we start talking about the health outcomes of all the people in our service area, and those health outcomes were getting worse. So we decided that we need to do more than what we're doing right now. And our board was very bold, thank you for the question, very bold, in saying we need to start looking at vital community conditions, We need to start looking at the root causes of sickness as opposed to just treating people when they're sick. And we need to look at communities as opposed to only looking at individuals when they approach us when they're sick. We also start realigning our grants. We do $65 million worth of grants this year. And all the grants we were giving were being done, and they were serving great purposes, and they were really doing great things. But when our board approved our brand new 10-year strategic plan in January of 2020, we said our grants have to be aligned with our strategic plan now. So our grants became aligned with our strategic plan, which meant that many of them were focused on upstream work, working at communities, working on the root causes of illnesses. And so that was probably the next big thing. And then we start looking into communities and realizing that communities hold the solutions. And all we have to do is be strong enough to truly listen. Listen to the perspectives that the communities give us, and they tell us what their real needs are, and then do something. But if we use our own perspectives, it's laced with our own biases, right? So unless we really listen to communities. So those were probably the biggest changes we made with the advent of our new strategic plan. And so with all those things, we realized that you have to push the finish line back. When you're looking at outcomes are going to occur later in life. And you have to be bold enough to push the finish line back. And that's when we start looking at this financial term. When our board did this audit of our investment, we've all heard of generational wealth. And we said we need to have a legacy of generational health. Because the people we're serving are of this generation. But if we do our jobs right, we're really talking about improving health and well-being for generations to come. And that's why we start talking about generational health.
Your results were groundbreaking. Why wasn't anyone listening to those communities before?
Well, even for us, it became uncomfortable because I grew up running hospitals. And so we made quick decisions. We had relatively quick outcomes. We could assess, we could pivot. And even for us, for me personally, and I think for some members of our team, it was a little uncomfortable saying, we're not going to have the solutions, they're going to have the solutions. They're going to tell us what really needs to be worked on, and then they're going to do the work, and we're just going to walk alongside them and let them do the work.
What's an example of a solution they offered for themselves?
Oh, it's tremendous. So our Prosperemos Juntos Thriving Together program. So one of the coalitions, we have 20 of these coalitions throughout our service area now, and they take a look at housing, entry-level housing, and so their solution and their problem was housing, the unhoused in their area, and so just looking at taking houses and fixing them up and not spending too much money, but getting them to the point where we have places for them. So these are organizations that all did good work, but they were working in silos. And so what we encourage them to do is to get together, listen to each other, and work together and decide what's the biggest need in your community. And then we would fund their work as long as they did it. So that's one example.
Finally, somebody was listening to them. Thank you, Jamie, for framing the concept for us. It's very inspiring to hear how an organization with a strong legacy and operating framework has the courage, really, to shift some of its key strategies and investment practices in order to deepen its community impact. On my show, and What Would You Do?, we sometimes have to give people a glimpse of a different way to properly perceive and then respond to injustice. Of what is possible when I'm curious if any one of you can share with us an example of what is possible when you make a conscious decision to change how you respond to the realities in your communities, as Jamie was mentioning. What unlikely partnerships and projects can you share that illustrate this principle? We'll start with you, Allison.
Yeah, sure. Well, I have to think about, when I think about unlikely partnerships, I actually think about the founding of mindful philanthropy, because It was initially one man who had lost his son, unfortunately, to an opioid overdose. And he was thinking about in his own philanthropy, he was one of the first employees at Vanguard. And as he was retiring and thinking about his philanthropy, he was going to fund addiction. And he was challenged by a number of philanthropists to say, what are the system issues that are underlying addiction? What is the co-occurrence of mental illness and addiction? And what are the things that need to be solved for? And so there were 4 funders that came together, and they began to study the philanthropic funding to mental health, addiction, and well-being. They commissioned a report through the Center for High Impact Philanthropy and found that it was 1.3% of foundation funding going to mental health, addiction, and well-being. And that was of the $500 billion annually in philanthropic funding. So they came together and they said, there is not an engine, a financial engine that is promoting funding for mental health and well-being. And mental health is instrumental to so many of the other issue areas that we care about that Jamie highlighted, whether it's housing or criminal justice or poverty. And that if you're wanting to further your outcomes in those areas, you have to integrate mental health into the work that you're doing. So they launched Mindful Philanthropy as an organization that would be that advocate for funding, not only increased funding, but also smart and efficient and effective funding that would unlock public dollars, other private dollars that would go to entities, organizations, public-private partnerships. So, we do our work as we convene philanthropy. We bring in researchers and experts to educate philanthropists to help them reduce the silos that they work in. We educate them and guide them through the research reports that we put out, which is over 19 reports now on the strategies that they can use to fund mental health. And then we uplift proven and promising opportunities. And so when I think about our work over the last 5 years, we're the newcomer to this group here, but their vision was to launch a brand new field of philanthropy, of mental health philanthropy, that would help to integrate mental health more effectively into physical health, that would advocate for it. And so we have done a number of things. One of our early wins, we worked with a group of philanthropists in Montana that came together, and we were educating them on how to fund youth mental health. And we had a very short window in which they could work on policy, and many of them had never funded policy before. In fact, they thought they couldn't fund policy. So we were educating them on, it's not that scary, you can do it. It can be a relatively low investment, and there's a huge return. And so I remember after Christmas one day being on the phone with one of the philanthropists, and we agreed, okay, we have a window of about 4 months to go after this before the legislative session breaks for a few years. And they made a relatively low investment of about $70,000. We brought in a partner that worked on the lobbying efforts. And that low investment of funds returned a $300 million public trust toward youth mental health. And it really motivated grassroots efforts. People were calling senators and legislators, people were advocating in the state, the lobbying efforts, but it was a great partnership and a collaborative effort among the philanthropists, the state, and so I would say that's one of them. One of the other unlikely partnerships, we were early to thinking about women's mental health. When nobody was talking about mental health, we were a team of women at the time, and many of us had lived experiences, with teenagers in our households, or, women who were entering perimenopause, or women in the workplace. And so women are such an integral part of communities, of stability, of thinking about access to health. And we started advocating for women's mental health and thinking about women's mental health through the lifespan. And we released 4 pieces of guidance, an entire initiative around women's mental health that led to a partnership with Kate Spade, who was already working on women's mental health, but began thinking about it more holistically, about women's mental health through the lifespan. They recently launched a global mental health fund for women, of which we're a partner, and that's doing incredible work around the globe. So a few unlikely partnerships.
Is it harder to find philanthropists in this current political climate?
No, I think, mental health is one of the things that I think everyone can agree on, right? It affects every single one of our families. It affects our communities. And so, no matter where you fall on the political spectrum, it's something that really unites us and brings us together. And we're seeing incredible interest from funders everywhere. We work with funders. We have a network of 1,100 funders in all 50 states and 12 countries. And they are everywhere on the political spectrum. And when they're in a room together, they say, I'm rarely in a room that looks like this. It's really phenomenal to be working on such an issue that brings us all together.
Inspiring.
Yeah.
David, changing how we respond to the realities of our communities. What unlikely partnerships and projects can you share that illustrate that principle?
Well, thank you, and thanks everyone for being here. I spent 30 years as a primary care doctor in Chicago's safety net, Cook County Hospital, Sinai Health System, largest private safety net in Chicago, and then got recruited to Rush University Medical Center, an academic health system located right on the west side of Chicago, a couple miles from the Loop. And my job was to be make Rush top in quality. And Rush is arguably one of the highest quality hospitals in the country. It's one of 20 U.S. News and World Report hospitals. But you heard last night about the Affordable Care Act, a tremendous panel last night. But one of the things that was not mentioned about the Affordable Care Act was the requirement to do a community health needs assessment. And I presented the community health needs assessment to our board, and it went like this. If you live in the Loop, I'm giving you current day numbers, so you could live to be 89 or 90 years old. Chicago's lakefront, many of you have probably been there.
Wealthier part of town.
Yes, the wealthier part of town. But if you go down the blue line, the Chicago CTA, 3 stops past our U.S. News and World Report hospital, life expectancy plummets to 63.
20 years?
Almost 24 years. And if it were a country, it'd be like the country of Senegal. Or if it were a county, it'd be the lowest life expectancy county in the United States. Think Sioux Nation in South Dakota. And I said to the board, you know, when something goes wrong with a patient in the hospital, we have to do a root cause analysis because you want to prevent it from happening again. So what went wrong in the neighborhoods? And we said among the reasons for this low life expectancy in West Garfield Park, the neighborhood that Martin Luther King came to,
Within a few blocks or miles, right?
2 miles away from us, was structural racism and economic deprivation, poverty. People are working, but they're not making enough. And said, if we really want to make a difference, we've got to make reducing these life expectancy gaps as important to us as improving quality. And the board took on that mission back in 2016 to do that very thing. And that meant then taking it to the community and developing the kind of partnerships that were mentioned here before. We've been there for 180 years, and we really hadn't had impactful community programs meant to move the needle on life expectancy. And so we embarked on that. We got other hospitals to join in an organization called Westside United, but largely partnering with the community around a number of things. So number one, realizing that when you're poor, when you drop below median income, where you live has a huge impact on how long you live, particularly as you get down below the 25th percentile of income. If you live in Aspen and you're poor, you're going to live a longer life than, say, Gary, Indiana. But you'll actually live 5 years longer if you're poor in New York City than in Gary, adjusted for race. So local conditions can make a huge difference in how long you get to live. 5 years is like curing cancer and eliminating cancer. These are big things. So what if we can improve the conditions in neighborhoods? And it's this connection between wealth and health. And so we say, how can we improve wealth in neighborhoods? Hiring locally, purchasing locally, investing locally. And we embarked on that in 2016, and we can see the fruits of those labors begin to bear now, all these years later. Of course, we had COVID in the middle, but that actually showed everybody that who you were and where you lived determined who got to live. But we call this an anchor mission, and we're doing a lot of work with local investment.
Wow. With those examples in mind of what we could do, what should we do to achieve health that lasts for generations? To any of you and all of you.
Yeah, I can jump in. So I think there are a number of things we can do, and I would say the first thing we need to do is think about shifting our mental model of how we think about health, how we think about investing. And so thinking about investing more upstream. So Jamie kind of illustrated that, the mental model and the mental shift that you guys went through, 8-9 years ago. So thinking about how do we invest in our communities and shift the power to the communities as we invest. There are a number of interventions that we promote within Mindful Philanthropy to funders that are helping to do that. So first, we think about community-initiated care. Like typically, we think about care delivery through service providers, clinicians, and we need those. But not every single person in the community needs those. When we think about upstream efforts, we can think about health promotion and prevention. And we think about barbers, like the Confess Project, that serve as a bridge to care sometimes. We think about coaches are a huge resource within communities, whether it's coaches for adults or coaches in Little League. Once they're trained and there are efforts underway to train coaches that can be bridges to care. So another is social prescribing. This is something that's relatively new to the United States, but it's proven to be effective in countries like Canada and the UK. For every Canadian dollar invested in social prescribing returns over about $3 or $4 to the effort. And so these are ways that you shift. It's a bold reallocation of funding to think about, social prescribing to belonging and purpose and social connection, where it enables communities to be connected and thriving through arts and nature and social connectedness. Another one is thinking about faith communities and the role that faith communities play to be on the forefront. We often know that when people are in crisis or trouble, they go to a person of faith, whether it's in their church, their synagogue, or they go to a leader, a clergy member within that their faith community. And so how do we train them as frontline workers to respond to those that are in need? So those are a few of the things that we think about as we uplift, upstream efforts within the communities and help to shift the mental model of what investing in mental health care looks like.
Jamie, what should we do to achieve health that lasts for generations?
Yeah, it takes me back to when we started our strategic plan in 2020. Our first focus area had to do with transforming our culture and our processes. And if we were going to make the big shift to going from health care to addressing root causes of sickness, it was a big shift, right? So we were mostly an organization of clinicians. So when you start talking about making that shift, they thought, what is this voodoo that they're bringing to this organization? What is this stuff? So you can imagine we had to communicate, educate. And back then, our engagement of our workforce was not bad. It was good. It was above average, but it wasn't fantastic. And so we're making this big change of what we're going to do. And we had to really just kind of work with our workforce to make sure they could understand and embrace and be engaged with what we wanted to do. I'm happy to say now that 2 years ago, we got into the top decile in our team member engagement. And this past survey we just took, we're in the top 95th percentile. So people, even no matter what their job is, they could be a nurse doing medical care, they could be a dentist, behavioral health, they are totally on board of everything that we're doing. So we're continuing to do our downstream work, and at the same time, we're looking at root causes, the work that we do. And so one example I'll give, I talked to you about Pros Primos Juntos thriving together. Another example is we were working with our board, and we're trying to figure out with our board, how do we as a board and as a leadership team truly hear from people with lived experiences? And we were struggling with that. We can go out in the communities and do that, but how does our board really hear from that? So our board had a great idea of developing community councils. And so we have 12 strategic areas of opportunity within our service area. And so we're setting up a community council in each one of these 12 areas. And community councils will be made up of at least 50% of the people with lived experiences. And then the other people on the community council are people that will have some influence within their community. So we have a we're developing a regional council now that they will report into, and then they will report into our mission committee so that we truly hear what their biggest needs are and their ideas on how to address those needs. So that's kind of how we realigned a little bit so you could take the number of people that we had to hire and form a whole department on our communities of solutions was all from scratch. And now we're about to hire our third person on community councils. So it's just a total transformation of the work we're doing.
David, what should we be doing to achieve health that lasts for generations?
I want to piggyback on what both Allison and Jamie said, because I think it resonates deeply with what we've done. So what if our mental model of health and how we think about it is all wrong? And as a doctor, who was, really doing all the doctor's things, jumping off of that was really important. So the mental model we hold around health and healthcare is wrong, but also the culture and climate that Jamie mentioned was critically important. So when I quit my job as a chief medical officer to become a senior vice president for community health equity, the word equity, which has gotten a bad name recently, I hope we can come back to that, it's critically important. But what if health does not arise from healthcare systems or clinics, but what if health arises from the community? And so there's a series of principles, and we, like I said, we went into the neighborhood that Martin Luther King visited in 1966, that went up in flames in 1968, and asked the community, what did you want? When they saw that life expectancy of 63, pastor, become a good friend of mine, said the Bible says the last shall be first. Now, most people investing would say, don't go to the worst place to invest. Go to the place that's next to the good place that maybe is not so good, right? Cluster investments. But we went to West Garfield Park. And a couple of themes that here. Number one, that health and wealth arise out of communities. And we need to think of the ways in which we can partner with communities in a meaningful way so they can achieve what they want. They wanted a wellness village. They didn't want a health center. They wanted a wellness village that's being built right now. There's an idea that came out of the disability rights movement that I think is aligned with nothing about us without us. That Jamie mentioned, it's not our job as a big institution. By the way, the power differentials, even if you're sitting around the table, are never equal. We're a giant healthcare organization. When you're sitting with the community members, those voices can be overshadowed. But we have to practice this idea of accompaniment, which is the idea Paul Farmer, the humanitarian physician, spoke about this, that we need to accompany the community on their journey for as long as they need us to be alongside them. And Allison, I'm hearing that in your work too. It's a critical idea. 3, and it's important to our work, and I hear it in Jamie and yours work, a preferential option for the poor. That where we have to start is for those who are suffering the most, and try to create those partnerships with them. And the last big idea is something that comes out of the sociology world. Is something called collective efficacy. See, one of the things that happens in communities that get disenfranchised or marginalized over time is the tables that often get set in an Aspen or my town I am, the tables where people, neighbors come together and organize, begin to become fragmented. Those tables need to be put together again where power can be leveraged. And an institution like Rush can help be at a table, but the table has to be led by the community. That's called collective efficacy. Communities that have higher collective efficacy, meaning something goes wrong in the community, they're out there doing something, have better health. And I think these are principles that apply across these domains of this work.
How have you reallocated your resources to achieve all this? Community impact, generational health.
Yeah, we recently it was probably about 2 years ago, we launched a couple of pieces of guidance for philanthropy. We were hearing there were a number of barriers to investing in mental health and well-being, and so we set out to address those barriers. And one of them that we heard was, we don't know where to invest. If we want to invest in mental health and well-being, where do we even start? And so we laid out, a case for investment and a strategic roadmap for investment. But one of the things that we laid out in that roadmap was that community was one of the most important things that philanthropists could invest in. And we know that people that are investing in mental health are really taking a place-based approach. But being able to invest in what the community needs. And, I think one of the things I didn't mention a minute ago, but I think as we think about workforce, which is a major issue when we think about addressing mental health and well-being, we have to think about a reallocation of workforce. Peer support and peer coaching models are one of the most effective interventions, and thinking about who actually is workforce and delivering care. So that's another way that we're reallocating resources and thinking about how can philanthropists and funds reimagine the workforce, whether it's a career ladder or it's different alternative forms of workforce that have lived experience, what you mentioned. And then thinking about addressing community needs and really uplifting what we know works, like community-initiated care. So we've taken some bold approaches in that and calling for bold amounts of funding towards some of these solutions that we know work, but really addressing those mental models.
Great. Jamie?
Yeah, I'm thinking of one example of how we reallocated resources in this work. And our CEO council, we talked about what do we want to do? What do we want to do with this new strategic plan? And one of the things we said, we want to be bold enough to work on generational poverty. And what are we going to do to break that cycle of intergenerational poverty? And of course, I sat there and went, I've been running hospitals my whole life. I know nothing about breaking the cycle of intergenerational poverty. But we studied a lot, we did a lot of research, and we found two major themes. One was to give cash assistance to people to get them out of survivability and get them a little bit over so whether they can actually do something to improve themselves. The other theory was coaching and facilitating families to help them with their financing and things like that. So we had the CEOs of the two largest organizations in the United States that did each of these two things come to us and present to us at the same time. And at the end of their respective presentations, we asked the question, well, what would happen if you did both at the same time? And there were crickets, because they were both so proud of their siloed way of doing it. And we said, we need to study this and determine how effective it could be, right? What could we do if we did both at the same time? And so we have just finished a 2-year study, a little bit over a 2-year study actually, where we had 125 families that we gave $500 cash assistance per month, another 125 families that we gave the coaching to through mobility mentoring, another 125 families that got the cash and the mentoring, and then a control group that really got nothing. And so all of these people, almost 600 families, answered the same questions along the way about how they're progressing. And you would think, well, why is the control group going to do this? So we did give them incentives to stay in the study and to answer our questions and things like that. So the study is now over, and now they're compiling the results. But this is just a way that we had to shift our resources for our people to focus on this thing, even though we had other people that we partnered with, going back to your partnership question, that were actually doing the work. And so we're excited about having a white paper that will not only direct us as Methodist Healthcare Ministries on what we're going to do to break that cycle in the future, but hopefully it's a white paper that other organizations, not only throughout the country, but throughout the world, can look at and maybe change the way we address that big need.
David, what can the rest of us do? What tangible shifts can we all take to our communities and our workplaces?
Well, I just want to start about this partnerships, because you make a mistake when you try to do it alone. I've learned so much from Jamie and Allison today, but this partnership in South Texas with Chicago has legs. But I want to just talk about sort of the way that we've thought about. So one, we've studied gaps enough. There's no more study that's needed. We have to take action. And we have to be driven towards action. I never thought me, as a doctor, still practicing, as a medical leader, would be in community economic development, but that's the field I'm in now. And partner with the community. Hiring locally is on our dashboard. And I'm not just saying local means Chicago. I'm talking about the neighborhoods with the lowest life expectancy in the city of Chicago. We hire from these neighborhoods and create career pathways to wealth. We discovered, after we showed that life expectancy map, that our own employees who lived in that neighborhood, 1 out of 5, were taking money out of their pension for evictions. And that was not our intention. And we did an internal revision of our own policies around it, but hiring locally, creating career pathways to wealth. So one of the Rush promises are job. But not only a job that pays well, but not only one that pays well, that you can ladder or lattice. Secondly, support local businesses. I said, why don't we open a laundry linen? This was back in 2016. What did I know about laundry linen? I just knew we had a lot of dirty laundry. Last year, laundry linen opened. We did not capitalize it, but we provided the dirty laundry. 300 people hired in a neighborhood that had not seen any new development. And people say, they have jobs. You know, what better could we do? So creating businesses off of our supply chain. The Sankofa Wellness Village is going to transform this neighborhood. But we're taking money out of our investments to invest locally, hyper-locally in this business. Today, before I'm walking, I'm on a phone call with a developer about helping, and Russia's going to lend money to this church to buy a lot where we're going to purchase the parking. But this sort of development, the idea that our capital can go to work in these neighborhoods that have been capital extracted. And so these are real things that we can do. I can see now, doing this now 9 years after we started, the reality on the ground of economic development that's occurred simply because we put our minds to it. And I think that's the alignment that we all have, right? It's that mental model of what's possible. And it's this idea that hope itself is not a fantasy. It's a muscle that needs to be worked. Of all the things I've done as a doctor, this is the most satisfying because you can see the material changes in people's lives.
Are other hospitals, other states, other cities paying attention, watching, following suit?
I don't run hospitals anymore, but I hope so. Yeah. I hope so. And I'll tell you what, our 50% partner is HCA, and HCA is looking for ways to do things in communities. And I went to HCA and talked to their leaders about a year ago because they were looking at the things we're doing at Methodist Healthcare Ministries. And so I talked about some things that they could do. I'm not sure they're looking at making multi-million-dollar investments to go out and work in communities, but if they can find things that doesn't cost them a ton of money that could make big differences in communities. One example is one that we're piloting right now with one of our hospitals, and that's SNAP benefits. In Texas, we're next to last in the country for people who are eligible for SNAP benefits that are actually receiving SNAP benefits. So we're now going into one of our hospitals, and we're going to talk to people as they're being admitted. And if we determine that they're eligible for SNAP benefits not getting it, we're going to make it very easy for them to apply. We're going to apply for them, get them the SNAP benefits, and then take an assessment. Because I would say when people leave our hospitals, they need good nutrition more than anybody. They're healing in some way, right? They need good nutrition. So many of them are going back to food insecure environments, and we need to make sure that we make those environments more secure. And so that's one of the things that we're doing. That's just one example of how we need to get hospitals to look at their communities more.
If I could answer, there's a national healthcare anchor network. I can tell you, for us, it's good business. When we started this work, we had 10 communities. Now we have 21, 40 languages. The words diversity means something. The word equity means something, and the word inclusion means something. Wow. That we cannot succeed as a business. This is good for business for us. Our board sees it's good for business, and when this pushback came, around DEI, we realized we couldn't let go of it because our employees and our communities demanded this of us. So there is a national movement, but more should do it, and we need the private sector to jump in as well.
Great. Time to hear from the audience. So we want to take some Q&As. There'll be microphones running your way. Let's see here. Right here in the front. Okay, you go first. Here's a mic. Hold on.
Hi, my name is Juanita Chin. I'm a sociologist and demographer. We have talks of a potential recession. My question is two parts. One, these types of investments are oftentimes those that are the first to go when a recession hits and financing becomes more difficult to provide at that time. Yeah. And so what is in place to ensure sustainability through economic changes in the country so that these types of activities and interventions persist when populations need them most is when we are hitting economic times that are difficult and they experience them more harshly than other populations. And second, in part with that, how are communities and how is power shared with the communities and those who are investing in communities to determine which activities are prioritized?
I can just speak from the philanthropic perspective that, one of the philanthropy's greatest roles is to fill gaps, right? When those gaps exist, when there's funding cuts, that they can step in and fill the gaps that are created. One of the things that we do with our philanthropic partners is really encourage them to be in the community as a partner and to be in it for the long haul. And so asking consistently their grantee partners, what is it that you need? How can we support you? How can we help you see impact? Is it burnout that your staff are experiencing? Then we'll give a wellness grant. But really thinking about how they can fill the gap that is created. We know that philanthropic funding is continuing to increase, and so we are advocating that people are spending above their 5% requirement. So push toward that 10, 20, even further percent requirement to be able to fill those gaps. So I do see philanthropy doing that right now, and we're continuing to encourage them to go even further.
If I could, that's a great both questions are great questions. So, in our situation, we put aside 1% of our endowment for these long-term community investments. There's something called patient capital. I'm very impatient, so I don't know what that means. But the idea, it's long-term, it's not short-term. It's outside of even our finance investment committee. It sits for these community investments, and many of them are very, very long-term subprime loans. It's not charity, though sometimes we do charity. So that's one thing. These conditions that we're looking at, say on the west side of Chicago, occurred all under Democrats in good times and bad times. So in a sense, we have to have long-term thinking here, and we know there's going to be the ups and downs. And third, we are a growing sector. We are always short of good workers. And so this hiring locally piece has been very intentional. But the power piece is critical. Power has always been asymmetrical. And even when you walk in with goodwill, the power's asymmetrical. And we have to be very, very mindful about the destructive role that big institutions can play in the process of trying to do good. And I don't know what else to be except mindful, but the decisions have to be made by the community. And that's, I think, it's a paradigm shift. It's not a rush coming and say, we're doing this. It's the community saying, we want this. And our job is then to figure out ways to help them get it.
Thank you, David. Out in the back.
Thank you. I got it. Thank you. Thank you all for doing this. My name is Chris Gates. I think it's a question for Jamie. Jamie, you used the phrase earlier, we were strong enough to listen. Could you say a little bit more about that? That's an interesting way to put that.
Yeah, because it's natural I'll speak for myself, and I think some of our leaders, it's easy to think you have the solutions and the ideas and know where to focus and just go do it. We had to be strong enough to say, no, we don't know. We are filled with biases. We don't understand. Each community is so different. And so we really have to listen. I was telling John earlier, one of our community councils that I spoke about came to our board advance. And at the end of their presentation, one of our board members said, "What's your biggest priority?" So this is a community council that is located in the Rio Grande Valley, one of the poorest areas in the United States. We thought that they would say clean water, food, poverty, something like that. And what they said was transportation, because a large number of their people live in the colonias down in the Rio Grande Valley. And so they said, many of us don't have a car. There's not a bus line that comes by the colonias. And those of us that have a car, usually it's one car. And so if you have someone in the household that goes to work, they take the car. So we are all just here in the colonias with very little services, and we are just stuck. So transportation, so that's what I meant by being strong enough to really understand each community is different, and they need to identify their needs. And then we need to be strong enough to let them do it and walk beside them and fund their efforts.
Great.
So it does take some strength.
Another question? Yeah, right. I'm sorry. Yeah, go ahead, right here in front. Yes. You with the button. Yeah.
Hi, my name is Brianna. I'm a PhD candidate at Virginia Tech, and I've done a lot of research with communities of Black women as well as in Black churches. And so, being a Black woman, I understand that I can go into these communities and I have trust. However, when we're talking about building community capacity and we're going into communities, I have two questions. One, how have you been able to build up that capacity for them to trust you, especially for minoritized communities, individuals who have been misrepresented and underrepresented? Then the second question for, I think it's Jamie, when he talked about how they walked alongside communities, what checks and balances or I guess accountability to support did you provide outside of just funding?
Yeah. If you don't mind, I'll start, and I'll try to address both questions. First of all, as far as the trust, you are absolutely right. That is key. So we really work on that community by community and making sure that we embed our people, our team members that are members of their communities. They live with them, they walk with them, they listen to them, they work with them. And I think a great example of that was during the pandemic. And in our area, there were a lot of people that we were trying to convince to get vaccinated, to get vaccines, because there was a lot of pushback on vaccines back then. And I think if it wasn't for the trust that we had, and then the people that we also brought in to help us with that trust, we would not have had the success rate. So if you look at the Rio Grande Valley and the rate of their vaccinations during the pandemic, which you would have thought would have been among the worst in the country, it was among the best in the country. We're not taking all the credit for that, but I think that was an example of the trust. And so it takes a little patience, and you got to stay there. It can't be a program where you go in and do something and then leave, but they got to know that we're going to be there forever, and that's what we really have. And the second part of your question was, I got to remember.
Okay, you talked about giving funding to communities in order for them to lead the projects, but I wanted to know if there was any oversight that you provided or any like supervision, things like that, outside of just giving money for them to run their projects.
We do, but we have to be careful, and that's another one of these uncomfortable things for us, because in the hospital world, we have very strict oversight and make sure that every investment we do has a return and is working and things like that. And we have to make small adjustments. They can't be fearful that their work is going to end because it's not perfect. So we have to work with them, walk alongside them, help them in their process of improvement. But they can't have a fear that their work is going to end because it's not providing the the perfect outcome. So yeah, that's another one that is uncomfortable for some of us, but it's essential to be that way to make sure that we aid them in their work.
Okay, time for one more question. Well, the last question, way back there. And of course, we can talk afterward too.
Thank you so much to all of y'all for the insights that you provided. My name is Ashley Gripper. I am a faculty member at Drexel University in Philadelphia, and I actually teach a course on community-based and participatory research. And one of the questions I ask my students is, how do we straddle the line of voyeuristic public health and saviorism with authentic and genuine connection? So I love that y'all have been talking about that, and it sounds like all of the audience's questions have been kind of dancing around that. And a question I have for you is around your metrics of success. How are you measuring your impact? How do you know that you're building and sharing power effectively? So to give you a little context, I also recently have developed a scale to measure something called community power, but among agricultural land-based communities. So I'm curious, like, what are you doing to actually know that you're doing what you want, what you intend to do?
David, do you want to jump in?
Well, it's a fantastic question, and I think one we ask ourselves all the time. The community came to us, a group of ministers, this started and said, we want a place to exercise in our neighborhood. When they first came to us, and I was chief medical officer, we don't do that, but now it's being built. It's what they wanted, which is a wellness village, arts and activism, indoor gym, YMCA, there is a health center. We're going to have a center for community well-being. Community grocer initiative, affordable housing is what they wanted. Entrepreneurial development. So at the end of the day, Jamie has said it perfectly, is you have to give people what they ask for and what they want. And there's been so much, in my positionality here, extraction over the years that gets to the measurement. We never demanded measurement when the capital was extracted. Disinvestment is called. When it was extracted, when Sears, 4 city blocks long, left North Lawndale in Chicago, we never asked the cost of that. And I think the right thing to do is just give back. You can see in this neighborhood where nothing had been done, things rising out of the ground that the community wanted. And I think the measure of success is what you see with your eyes. Now I will tell you, I'm going to meet with legacy residents of this neighborhood on July 8th and taking my team, because they have big concerns. They've been there for 3 generations about being gentrified out, and we've got to balance that at the same time. So I would love to see your scale. Let's get you to come and help us measure.
David, Allison, real quick. Okay.
Quick. The scale was actually directly asked for from land-based farmers because they said we don't have a way to assess what we're doing, and I'm also a farmer, so I'm like, all right, well, how do we build this thing together? So yes, to what you're saying.
Love that.
All right. Well, David, Allison, Jamie, thank you so much. How about a big hand for these folks doing such great work, huh?
Thank you.
Thank you all so much. Thank you all for being here.
Thank you.